Hello, and thank you for joining today's NCCN patient webinar, Know What Your Doctors Know, Kidney Cancer. My name is Tanya Fisher, and I am the moderator for today's webinar. NCCN stands for National Comprehensive Cancer Network. NCCN is a not-for-profit alliance of 31 leading cancer centers across the United States devoted to patient care, research, and education. NCCN Foundation is a nonprofit organization that raises funds for NCCN patient resources, including new and updated patient guidelines, as well as patient webinars. These are funded using financial support from generous donors. The NCCN guidelines for patients are based on the NCCN clinical practice guidelines used by healthcare providers worldwide. They explain the same options for cancer care, but are written for patients and their caregivers, family, and friends. You can view and download free copies of the guidelines for patients from the NCCN website. High-quality printed copies of the book can be purchased through Amazon. The Know What Your Doctors Know webinars complement the NCCN guidelines for patients. They cover a series of topics discussed by expert presenters. Viewers have an opportunity to ask questions at the end of the presentation. This brings us to the presenters for today's webinar. I'm very pleased to introduce Dr. Brandon Manley. Dr. Manley is a urologic oncologist at Moffitt Cancer Center in Florida. Following Dr. Manley, we will hear from Sarah Hart, who is a regulatory and accreditation consultant also at Moffitt Cancer Center. Our third presenter today is Brian Lewis, patient advocate. Brian is president of KidneyCAN and vice chair of the International Kidney Cancer Coalition. Now I will turn it over to Dr. Manley.
Thank you, Tanya. And thanks to the NCCN for the opportunity to come in and talk to all the wonderful patients. I hope that I can provide a little bit of education, but certainly within this time frame, we're not going to be able to cover it all, but this should hopefully be a good start for anyone who's just starting on their journey or continuing on it. So real quick, sort of breaking it up into three parts, talk a little bit about the epidemiology, what we know about kidney cancer. Like many cancers, we don't have all the answers, but there's certainly some things we do know. And then spend a little time on the pathology, which is sort of an important point for any patient who's been diagnosed with kidney cancer, because pretty much all of our treatment, either recommendations or management strategies are based largely on the pathology. There's different types of kidney cancer. And then discuss some of the management options that are typical for patients newly diagnosed with kidney cancer. So broadly, when we talk about kidney cancer, the technical sort of name for it is renal cell carcinoma. You can have tumors arising in the kidney or spread to the kidney that actually aren't quote unquote kidney cancer. So when we're talking about tumors that originate from the kidney themselves, those are classified as renal cell carcinoma or RCC. And it's actually a pretty heterogeneous group. So there can be actually quite a few different types of tumors or renal cell tumors. And it's one of the more common tumors both in the US and nationally, and with coming about the 14th most common worldwide. This typically is a tumor that manifests, at least in its sporadic form, in older patients, so around age 64. There is this slight time predominance towards men being diagnosed more often than women, although over the last several decades, we've seen that come closer to being an even distribution. Overall, it's estimated the lifetime risk of developing kidney cancer in men is about 1 out of 46, and the lifetime in women is 1 out of 82. The most common histology that we see, and this is about 75% of the cases, is the clear cell renal cell carcinoma or ccRCC. This, because of how common it is also the most aggressive type, so we see it across all stages of the disease. It's also what is largely used to develop clinical trials and our treatment strategies because, again, how common it is. About 30% of patients present with metastatic disease, meaning the kidney cancer is already spread throughout the body. Okay, this is equivalent to what would be stage 4. So this just gives a sort of recent breakdown, not the most up-to-date, but really things haven't changed too much. You can see for men, it's the 5th most common, and for women, 7th most common cancer in the US. Worldwide, we see that, like many cancers, it tends to be a higher incidence in developed countries. Again, when you consider the lifespan of those patients in those countries, this makes sense. It's something, again, where you do see a little bit of a higher incidence in patients from European descent compared to other ones. Certainly, it's not the end-all be-all, but it is something that epidemiologically has been noted. So this sort of breaks it down into the 4 stages of kidney cancer. Like many cancers, we have this sort of classification, stage 1, 2, 3, and 4. For stage 1 and stage 2, tumors, you're usually talking about what we would consider localized disease, meaning that the cancer is not spread. It appears to be confined to the kidney itself. It doesn't typically have involvement in any nearby organs. And these are tumors that are primarily treated with surgery or, for some patients, ablation treatment. Stage 3 is sort of the in-between stage. These are tumors that tend to be bigger, more advanced. They can have tumor thrombus, which grows into the main veins. They can also be involving directly or indirectly some organs that are close to the kidneys. If they involve an organ directly, then technically that would be stage 4. But a lot of times we don't have all that information just based on CT scans. We only find that out after surgery or some diagnostic procedures. Stage 4 is broadly classified as those with metastatic disease, although, like I said, you can have disease that necessarily hasn't spread throughout the body, but if it's involving nearby organs directly, and we know that pathologically, then that would be classified as stage 4 as well. Below, it also gives you some of the typical management options at these various stages. So histology, like I mentioned before, the clear cell histology, which you can see sort of up in the top left, is the most common. We know that this histology primarily results in an alteration of a gene called VHL, or von Hippel-Lindau. That's an important gene because there is some hereditary syndromes, most notably von Hippel-Lindau syndrome, which is different than the sporadic type I'm talking here, where patients have genetic predisposition to developing these tumors. In the sporadic form, like the name would say, these alterations in the gene happen in a more sporadic manner, meaning you didn't inherit them from mom and dad. They call it clear cell because, as you can sort of make out on the pictures, right, you see these cells, and the nuclear, which are the dense parts there, are surrounded by this sort of clear, empty space. And that's actually a manifestation of the processing of the tumor samples in the pathology lab. It's not how you would actually see it in a person or something. You don't have these sort of air-contained cells. And then some of the other types that we more commonly see are the papillary types, type 1 and type 2. Those are broadly sometimes lumped together, although there's certainly some significant differences in both the biology and how we manage them. So they're important differences. Sort of the third most common one we see is chromophobe. That's about 5%. These tumors tend to be more indolent compared to papillary and clear cell, but they can still be locally aggressive and certainly in some cases can still spread. There is other tumors that we see. These tend to be much rarer. They broadly encompass about 1 to 2%. These include the translocation tumors, which is the XP11.2, the medullary ones, the collecting duct ones, and there's also a group of tumors which we really haven't figured out where they sort of fit nicely within a box. They all have some differences about them, and so those ones a lot of times will be sort of classified as unclassifiable. This is the official list of all the renal cell tumors that you can have. Again, the ones I mentioned before are really the ones that are most clinically relevant, but there is some rarer entities that from time to time we will see, and they have some differences in how we'd manage them. So it's important to have good classification of what histology you have, because a lot of treatment decisions are driven by this. The hereditary ones, like I mentioned, those are ones that can look the same under the microscope, but we know that the development of these tumors stems from patients having in their genetic, germline alterations that they inherit from mom and dad that predispose them not just to kidney tumors. For some of these syndromes, they come with a myriad of other issues or other tumors, in fact. These are the most common ones that are up here. Like I said, the first one, VHL, is sort of the most well-known, most well-defined, but there is other ones. We know quite a bit. The ones up here, obviously, we know the most on, and we have good studies showing us where the alterations are, how they sort of manifest, and we get a good sense of the biology, but we don't have the whole picture. There's certainly some patients who have all the clinical signs, meaning a strong family history, multiple tumors, young age, but we can't pin down the gene. Overall, about 5% of patients that we see with kidney cancer fall into this hereditary group. So it's still a relatively small group, but it's an important one to define because, like I said, these patients could be at risk of recurrent tumors, multiple tumors, other tumors in other sites. So knowing this is important for patients. So the workup For most patients, especially at a tertiary referral center such as Moffitt, where I work at, is most of these patients have them diagnosed incidentally, meaning that they didn't necessarily have things done to look for kidney cancer, but they came in, say, because their gallbladder was maybe bothering them or some colon or stomach issues. And in most patients, especially in industrialized countries, in the US, if you go into the ER with any kind of general abdominal plate, you're probably going to get a CT scan of some sort, or at least some kind of imaging. And that's where we find most of these tumors, actually. So patients don't actually have direct symptoms related to them. We can learn a lot from that information. We know that solid lesions and the size of those lesions is very predictive as far as the correlation with it being malignant. We broadly use a cutoff of about 4 centimeters, so anything less than that we consider a small renal mass. We know traditionally that if you just take all tumors under 4 centimeters, about 75% of the time they'll be malignant, but that does mean there's about a quarter of the time when they're not. So there's some features within the CT scan we can use to help with that. Again, is it totally solid or is it cystic? Does it have enhancement, meaning the contrast dye they give you, does it light up, so to speak? Those things can all help us sort of refine that, the chance of it being malignant. So a lot of times people think, because these are tumors of the kidney, that almost everyone will get blood in their urine, but actually that's a relatively rare symptom. And usually we don't see it until the later stages with really big or bulky tumors. So you can see it, but it's not as common as you would think. One of the important things whenever you're sort of staging patients newly diagnosed is getting good imaging. And a lot of times, like I said, if a patient goes into the ER, their imaging isn't designed to look specifically at the kidney. So a lot of times that's one of the first things we do is repeat it, because it does give us a lot of information. MRI, while it's often recommended by radiologists, always isn't as helpful, and actually a lot of times it can be not helpful. Now, saying that, there's some lesions where it clearly can play a role, or in patients who simply can't get CT scans or really can't get dye, it may be an opportunity to get some further information. One of the things I see pretty commonly is patients coming in with PET scans, and if you're solely getting a PET scan because you have a mass on your kidney, that's really not needed. One is all of our kidneys light up on PET scans, so it's not going to tell us anything about the tumor itself. And we know that PET scans are not very sensitive or specific for finding kidney cancer outside of the kidney. So a lot of times it ends up being an unneeded study, or it finds something else that we have to now work up and sort of delays possible management for a patient. Renal ultrasound, although it's what we consider a lower technology, does have some value, especially in small renal masses, because we can actually look at the functionality of these tumors in real time. You can see if they have increased blood flow, which we know tumors do, versus cystic, meaning is it just a bunch of fluid and it doesn't really appear to have any blood flow to it. Those things can be really helpful in managing, especially the smaller renal masses. For tumors that are any kind of significant size, 4 centimeters above, we usually like to get a CT of the chest. Again, we know that most kidney tumors, the first place they go is the lungs. That's certainly not the only place. Can be other places, but as part of the staging workup for those larger tumors, we like to rule that out. For patients under 4 centimeters, usually a chest X-ray is more than significant. So biopsy is something that has a sort of long history of not being advised in kidney tumors. I think this was back in the 80s and 90s before the biopsy technique really changed. In my practice, and I think in many patients or many providers who see a lot of kidney cancer, we have a low threshold to use a biopsy if we think it's going to change management, meaning like we think based on the results, we may or may not do something differently or recommend something differently. There's other factors that consider a biopsy. If you have it very cystic, meaning a lot of fluid, we tend not to stick needles in those things, obviously for the theoretical risk of seeding and stuff like that, but that's pretty rare. When you look at the modern literature, we just don't see it very often. Also, the location may not be ideal, even if it's a small renal mass. If it's sitting close to big blood vessels or organs like the pancreas or something, it may be higher risk for complications. So for the smallest renal masses, and again, that's sort of the under 4 centimeters, and especially under 2 centimeters, there can certainly be some benefit. When we have patients, especially patients with comorbidities who are elderly and may not be ideal for any kind of surgical or intervention, getting a biopsy can provide a lot of comfort for both patients and providers that even watching these tumors, at least in the short term, may be the most favorable treatment diagram. So I think it's always something to consider for patients who have multiple masses or they only have one kidney, say they were born that way or they had a previous surgery. I usually get a biopsy when feasible just to really make sure that if we're going to put this patient through any kind of treatment, especially surgery or something, that we're doing it for the absolute right indications. Active surveillance is something where we sort of keep an eye on tumors, and this is not just unique to kidney cancer. We do it in many other cancers, but it's something that more recently has been employed in kidney cancer. The sort of ideal candidate for these ones are really small masses, 1 to 2 centimeters, and we know historically and epidemiologically that those ones have a very low chance of spreading if they're at that size. So you're not really missing your window to cure. We also know through some clinical trials that some of these tumors can not grow for years and years and years, and obviously we can spare those patients possible intervention, especially if they're higher risk. These tend to be the ideal patients over age 70, some comorbidities, including not great kidney function or not a good heart or lungs, that they may be the most that benefit from this management strategy. Tend not to be something we employ in younger patients, just because again their lifetime risk of something happening or the chance to miss some kind of treatment window is not always ideal for that patient. But this is a discussion you should have with your provider, because some patients prioritize other aspects of their life other than just the quantity of their life, and that's something that should be discussed. It's important that you have a patient that can get back to see you or see a local provider on a regular basis. So for instance, patients with no insurance or not great insurance coverage, or they're worried about their insurance dropping off because of their work, they're probably not the ones you want to be doing this kind of management with. So there is sometimes, again, when I talk about some of the features of the CT scan, this is a patient who came in, had a mass. Again, they weren't symptomatic from this mass, but what you can notice here where this yellow dot is pointed out is that dark part of the tumor, and that's actually fat. And so this actually is pretty diagnostic for what we call an angiomyolipoma. This is important because these are, 1, benign tumors, and 2, we don't treat them with surgery. We actually have our interventional radiology colleagues perform an embolization of these tumors when they reach a certain size, and it's very effective. It's very minimally invasive. And so instead of risking this patient losing a kidney possibly or having a complex partial nephrectomy, you had a very easy way to treat this patient appropriately by just making the correct diagnosis up front. Other times we have patients, such as this one, where they have not the greatest kidney function. They have these masses that, again, this is sort of one of the ones where we got some value based on an MRI compared to a CT scan because this patient couldn't get any contrast imaging. Again, this is a small mass. It's in a favorable location for a biopsy. We were able to get information showing that this was a chromophobe, a very indolent kind of tumor, and so therefore we were able to sort of offer this patient an active surveillance protocol versus upfront treatment. Other things is a lot of times you have what can be considered cyst, so they're predominantly fluid filled, but they have some small component of a solid structure, and we have a classification for that called the Bosniak system, but it's not perfect. And again, we've learned more and more, especially these tumors, that even when they are tumors, they tend to be very indolent. And so for patients who have masses that are predominantly cystic, I really emphasize at least keeping an eye on them. And this is actually a patient of mine. She was a younger patient. Her lesion was right in the center of the kidney, so it's not ideal for surgery because of the risk of kidney loss. And there was some time when this cyst was growing, and these things are living organisms, right? They're part of your body, so they can grow, they can shrink, they can do lots of things. And this is sort of 3 scans showing the initial one where the cyst actually got quite large, but if you notice that it was just the cystic component, not the solid component. And then actually the cyst regressed on its own in follow-up scans, and so we were able to spare this patient any needed intervention. Ablation is another management option, especially for smaller tumors. I tend to use sort of a 3 centimeter cutoff, as a lot of the data has sort of shown that when they're 3 centimeters, as long as it's in a favorable location, that the 5-year recurrence risk is pretty much equal to partial nephrectomy or surgery. For tumors that are above that, we do see some separation in the curves as recurrence risk. But again, you have to consider the patient as a whole. Sometimes patients are really just not good surgical candidates, really bad lungs or really bad heart, right? And so you really have to sometimes consider these options as alternatives. For those that are bigger than 5 centimeters, there's really rare exceptions. There is times where sometimes we can use a combination of embolization to try and shrink the tumor so that it gets better ablative features to it, or a size that we can really feel more confident about ablating the tumor completely. There's a lot of different ways to ablate it. The most common is cryotherapy. That sort of has the longest track record in kidney cancer, but other things like radiofrequency ablation, which tends to be less favorable, but things like microwave ablation can also be considered. Surgery after any kind of ablation obviously is higher risk, and so that's something important to know beforehand, right? If it doesn't work, what are my alternatives afterwards? So this is a patient here who, again, had, favorable location. It's sort of on the outside of the kidney, right? So this person really has all options available to them. You can ablate this. You can do surgery, certainly, on this. There's even, again, depending on the patient's desires or comorbidities, an option to watch a tumor of this size. So this one is sort of all options on the table. Other times you have tumors where you don't have all options, because this one, as you can see, sort of sitting in the very center of the kidney. It's close to a lot of important things like the drainage of the kidney. The duodenum, which is part of our small bowel, runs real close there. So for this one, really surgery is the only option, because with surgery, you can move things around, right? We can get those things out of the way that need to get out of the way. Whereas with ablation, you have very limited ability to move things within the abdomen. So surgery is still the standard of care for small renal masses, localized ones. There has been a clinical trial. It's not the best clinical trial in that it didn't accrue all of its patients. And while it was a randomized clinical trial, there's still a lot of debate within our own specialty about the merits or more the outcomes. It did show, and this wasn't surprising, that radical nephrectomy wasn't inferior to partial nephrectomy. In fact, it showed that partial nephrectomy really didn't have any benefit as far as overall. Well, I take that back. So when they sort of look at the intention to treat, which is all the patients that signed up, radical nephrectomy was found to be superior to partial nephrectomy in overall survival. But the patients who had the partial obviously had better outcomes when it comes to chronic kidney disease and stuff like that. Again, there's some severe limitations of this. This hasn't been repeated. I don't know if it ever will be. It was a tough trial to get people to sign up for, a tough trial to have physicians buy into. It's hard to be totally agnostic when making these decisions, radical nephrectomy versus partial, especially if you think it's feasible. Plus, before this randomized trial and still since then, there's been lots of data, again, not in a randomized trial, so not the gold standard, but just a whole bunch of data from retrospective and comparative trials that have shown, that a partial nephrectomy is just as good as the oncological outcomes as a radical nephrectomy, with the added benefit of preventing chronic kidney disease lifelong. So again, when we consider which patients we can perform partial nephrectomy on, this comes a lot down to experience, right? This is a patient who had a mass that's certainly not in an ideal location for partial nephrectomy, but if you notice on the screen, this is their only kidney. So really, this is the only chance this patient had to be not on dialysis, which, again, don't have time to tell you here, but you probably all know that dialysis is not a good thing. There's significant mortality associated with dialysis. And for patients who aren't ever eligible for kidney transplant or anything like that, right, that may not be, that may be all they're ever going to be is dialysis. And so for patients such as this, it's really important you get to somebody who has a lot of experience, can offer you different techniques, because these patients, while they're certainly complex, you can have good outcomes both oncologically and functionally. And this patient is more than a couple years out now and has a good majority of their kidney, not needing dialysis, and is disease-free. So yes, partial nephrectomy offers a lot of benefits, but it is more complex, right? There's more risk of side effects from a partial nephrectomy than a radical. A radical is actually relatively easier when you're taking the whole kidney. So when you only take part of that kidney, or the part with the tumor, right, you can have urine leak, you can have things bleed, right? Our kidneys, they filter our blood, so they're very vascular organs. So there's also decisions between minimally invasive, which is most commonly robotic in this day and age. Very few people, if any, really are doing any pure laparoscopic, but there is some out there, and if that's something they're really good at, then it's certainly not a bad approach. More commonly, the decision is between robotics versus open. Again, a lot of this has to do with the location of the tumor, the patient's history, have they had multiple surgeries, and then obviously the surgeon's preference. So it's really important to try and find those things out when you're meeting with your providers. Some people, wouldn't consider doing robotics, whereas other people would. It's hard to sort of know which one's the right one. The key is getting to somebody who does a lot of this so they can really go over the risks and benefits of those different approaches. After surgery, most patients do well. The time when we see any complications is usually in the first 24 to 48 hours. Most patients after minimally invasive kidney surgery will go home the next day. A lot of times for patients with an open procedure or more complex, they may be here an extra day or two, but if complications are going to happen, they usually happen in those first 24, 48 hours. So we find out pretty quick if we've sort of made it through without a bumpy ride or not. Now, certainly you can have longer term complications. One of the unique ones to partial nephrectomy is actually you can get what's called pseudoaneurysms or AV fistulas. And these typically occur about a week, but more classically 2 weeks out. And really what it is you get the kidney that heals. Some of these bigger blood vessels heal in a not good way where they sort of connect directly to each other or to the urinary system. And so the most common thing that patients see when this happens is blood in their urine. And it's usually not a subtle amount of blood. This is blood that sort of shows up. It's totally painless, happens about 2 weeks after. It's pretty classic. That risk is relatively small. It's about 1 to 2%. Depends sort of where the mass is. The more central, closer to bigger blood vessels, there is a slightly higher risk of this versus smaller masses that are more on the periphery. Systemic treatment, this gets a little more complex, and currently this is reserved for patients who have metastatic disease, so it's spread elsewhere. But more recently, and I didn't update this in time, but 2 months ago, there's approval for the first immunotherapy drug to be given in the adjuvant setting, which is pembrolizumab. So this is now a new tool that we can provide patients, especially those patients that we think at the highest risk of recurrence. Again, since it's only been out for a couple months, there's still a lot of discussions that need to happen between patients and providers about who's ideal for this, because it's a drug that can have some not good side effects. And so we need to sort of weigh those risks versus the benefits for each patient individually. And this is actually quoting that trial, the adjuvant pembrolizumab, which was presented in New England Journal of Medicine a couple months ago. Again, it was a well-conducted study. It definitely showed good results, favorable results, but there's still a lot of questions that we need to figure out, right? The follow-up for the study is relatively short. The definition of a high-risk patient is certainly debatable. There's some obvious situations where we say, okay, this patient's certainly at high risk. But then there's a lot of patients in the gray zone where you sort of have to weigh other factors like the patient's preference, right? Their ability to tolerate this treatment. They may have some medical issues that make their risk higher than somebody who would have been on this trial. So those are all things that you need to sort of consider in talking with your providers. And we are going to have other trials and other drugs coming into this space in the not too distant future. So there's going to be even more options. So these issues are just going to be continually present until we come up with some really good ideas on how to select patients appropriately for this treatment. I'll turn it over to Sarah. Thank you.
Okay, thank you, Dr. Manley. So I'm Sarah Hart, and I've been a nurse for 12 years, so a little bit of my background. I did inpatient chemo, outpatient infusion center, a little bit of hospice, and for the last 6 years, I was a primary nurse in the genitourinary clinic at Moffitt Cancer Center, working with patients who had urinary cancers. And only recently did I switch over to regulatory and accreditation consultant. So I help the hospital maintain continuous Joint Commission compliance and optimizing our patient safety as a hospital in general. So the goal of my portion of this presentation is for you to have something to refer back to, for patients to have, patients and caregivers. I'll go over some common side effects you might have with systemic therapy. And there's so much information to write down. So some takeaways to bring to your doctors and things to remember. Those are my goals. So side effects of systemic therapy. So the systemic therapy kind of breaks up into immunotherapy, oral targeted therapies, or a combination. And those could be for short periods of time to the rest of your life, to somewhere in between. And so it's such a wide range of treatment plans. So we're going to review some of these side effects, and I'm going to go into detail with the top 5. But these are side effects that you might get with any of the systemic therapies that you might be prescribed at any point with your providers. And these are treatments that are given typically for stage 4 kidney cancer. But as Dr. Manley mentioned, they're starting to look at neoadjuvant treatments as well. 2 of them I'll highlight here, rash and hand and foot syndrome. Those are side effects that you might get with some of these treatments. And sometimes the provider might defer you out to a dermatologist or your primary care to help manage those symptoms. And pneumonitis is something I'll review again later as well. And that's where you have kind of a process in your lungs where it's more difficult to breathe. And so just with any change, the key takeaway for this slide is any change that you notice while taking these systemic therapies is call the doctor. Get to know your doctor team, get to know your nurse team, and they'll walk through whatever symptom you're having so that way they may remain maintainable. And then with with taking systemic therapy, you'll be visiting your doctor or the doctor's team, maybe a nurse practitioner or a PA, and you're getting blood work. Sometimes it's usually monthly or so. And so we'll have you check your blood pressure regularly at home. We'll check your blood work. And so that's kind of addressing the final two. But I'll go into the first 5 into detail here. Diarrhea, that's one of the common symptoms or side effects of all of these treatments. And so diarrhea, there's some general things that you can do, and it'll take a lot of mixing and matching of different things to try and help manage that. Drink a lot of water, talk with your doctor, talk with your nurses. They'll mention the BRAT diet, and those are different things that you can eat to help manage the diarrhea. And avoid using a straw. There's some over-the-counter supplements you can try. So diarrhea really becomes a main concern with a lot of these medications. One rule of thumb is wait until, if you have 4 or more stools a day, definitely call the doctor, or something more than your norm. If you normally have 1 a day and now you're having 3 a day or whatever it is, or more than that, keep the doctor updated. So then we'll move over to fatigue. And these next couple slides are just ways to prevent fatigue. These systemic therapies really can just make you kind of more worn down, feel kind of weak, kind of tired. And the main things the easiest things to do, but it's also easier said than done, that's exercise. Exercise and drink water. Exercise and drink water. Even if that means walk to your kitchen and back 3 times a day, or walk to your mailbox and back 3 times a day, or whatever's manageable for you. Do small portions throughout the day, and that will keep you busy and keep you moving. And that way, if you're too tired, then you're just removing one of those small activity portions instead of your entire exercise routine. And again, work with your doctor, work with your nurse, let them give you more tips. If fatigue is an issue, they may discuss with you pros and cons of changing medications. And so keep working with your doctor, and then you keep these slides handy. Use them back as reference in case the symptom comes up later. It's not an issue today, but these are some really good tips and tricks. Mouth sores is another issue that you might come across with any of these medications. There's a couple things that you can do to prevent them or to keep them from becoming more of a problem. Right in the middle of this slide, there's a kind of a salt mixture that you can do, or baking soda mixture. And you can rinse that in your mouth and spit it out. You can do that 4 times a day. You can do it before and after meals, kind of whatever mixture of that works for you. And sometimes you may need it, sometimes you may not need it. But then you can also try, there's over-the-counter biotin type of medicate or supplements that is rinse in your mouth and spit, or even children's mouthwash. It's any mouthwash that doesn't have the alcohol in it can make it easier for you to tolerate. It won't burn your mouth so much, and then that way you can feel comfortable keeping your mouth clean more often, and that will help prevent these mouth sores. So, and then here's some diet tricks to help with mouth sores and avoid alcohol, acidic foods, sharp foods, and eating popsicles really can help. So nausea, the next couple slides talk about nausea. There's many things you can do to help with nausea. This is another one of the main side effects that might happen with just about all of these treatments. Some worse than others, some no big deal. But talk to your doctor. There's some medications they can prescribe to help mitigate that nausea, and then stay hydrated. Stay hydrated, drink water. refer to these tips. I don't need to read all the exact lines to you, but you can also try drinks. Get used to trying things like Boost, Ensure. Boost also has Boost Breeze, which is like a fruit punch kind of version, and so it's not that milky base, and some people prefer that. And then just try whatever works for you. Honestly, if food tastes good, do it, eat it, and eat what you can. Some days you may feel better than others, and take advantage of those days. And then just know just keep your doctor updated. I know I sound like a broken record, but I do mean it. That's exactly what they're there for. Don't tough through these side effects. If you are noticing these, or if your caregiver is noticing these, please keep the doctor updated so they can help manage it in whatever way they can. Poor appetite is kind of a segue from the nausea, and sometimes the nausea medications they'll give you, you may not feel nauseous, but you don't feel like eating. Sometimes you can try that nausea medication before a meal, and then 30 minutes before that meal, then you might feel up to eating a little bit more. So sometimes little tricks like that can help. Just trial and error with the medications you have. So then this kind of goes through a few more tips and tricks of what to try, including the Boost. You can do other meal replacement drinks, but just keep a really close eye on that label and how much calories you're getting. So is it a meal replacement drink for diet purposes versus a meal replacement drink for nutrition purposes? So, and then here's more, again, physical activity can very much help. It may seem easier said than done, but the more you get up and move, the more you do feel like eating. And then here's a list of high protein foods and high calorie foods. Keep those handy. The next couple slides, this is similar to the slide that Dr. Manley showed earlier, and it's just a list of medications. The reason I like this one is first-line therapy for clear cell carcinoma, and then non-clear cell, and then next-line therapy options for clear cell. I go through these kind of quickly just for you to have as a reference to show how your doctors might be coming to the decisions they're coming to, and have that open conversation with them of why is one better than the other, or if one doesn't work, which ones are your next options. And so those are important conversations to have, and important resources to know exist. There are many different types of therapy, and so your doctor will want to find the one that works best for you. This is a similar slide that refers to the side effects that most are associated with that specific medication for the systemic therapies. So whether it's an oral medication or it's an IV immunotherapy, they each have their own specific list of common side effects. And so those are, just keep that handy to refer back to. This is a list of immunotherapy side effects, immunotherapy being IV. And it's a very long, you'll notice the list of side effects for these treatments tend to be very long. And the way I like to refer to that is the immunotherapy teaches your body to work at the cancer cells, but that means it can then also work at any other cells in your body. That's kind of the super simple way to look at it. And so that's why it could be any portion of your body could react in that surprising way to the immunotherapy. And those side effects could occur on day one, or 2 months later, or even as much as 2 years later. So even if you're done with treatment and then something surprising happens 2 years later, you think back and, oh, it could be the immunotherapy causing this, and that can adjust the way it's treated. And the pneumonitis is one of those where normally I can do a round of golf, no problem, but now it really makes me short of breath. You might have had immunotherapy last year, and so think about that when you're talking to your doctors. So, and then this is my list of resources, several very reputable resources here for you to read through, learn about the cancer that you have, and there's some really good support groups here, and so just utilize all the resources that you can find. And then if financial resources are needed, talk to your doctor, talk to your pharmacist, and a lot of the drug companies themselves will have financial resources to help with that burden. So thank you so much, and I'll turn it over to Brian.
Great. Thank you, Sarah. And thank you, Dr. Manley. Also, thank you for the NCCN for this opportunity. My name is Brian Lewis. I'm the president of KidneyCAN. We're a research and patient advocacy organization located in Philadelphia with a team across the country helping us accelerate cures. I'm going to see if I can take advantage of presenting here. So KidneyCAN was started in 2019. I'll come to that in just a minute. Today's topics I'm going to highlight real quickly are our origin and our mission. Then we're going to talk about supporting patients as well as advocating for research funding, and then ultimately accelerating cures. Let's see if I can do this. So the genesis of KidneyCAN, I was living on Capitol Hill for 10 years and doing some active work on Capitol Hill with the House and the Senate. Worked for a trade association in Washington when I was diagnosed with kidney cancer. Fast forward, as I was doing some work on the Hill, I realized that kidney cancer was unknown basically in Congress, except for a few instances where a few folks had contracted or had been diagnosed in the past. And so as I was going along talking to Congress and talking to different offices, I had the opportunity to go to Dallas, where I was fortunate enough on the Smart Patients application, which we'll talk about in platform. I was able to meet Ralph and Brenda Knapp, as well as a number of other caregivers and patients around the country. And with the Knapps, we got together, and the Knapps were influential in raising funds for one of the first clinical trials combining a vaccination with kidney cancer treatment. And so they were able to raise some funds and fund that. And we got talking and decided 1 + 1 might equal 3. And so we merged organizations and became KidneyCAN. And so when you think about KidneyCAN and what our team does in trying to think about KidneyCAN on a regular basis is we want to accelerate cures. Everything that we're doing needs to be accelerating cures. Otherwise, it could be a waste of time. And so when we realized that kidney cancer is unknown generally, we wanted to raise awareness. We felt as if raising awareness would then lead us to doing more advocacy work for our disease. And that advocacy, especially in Washington, could lead to increases in research funding. And so we were able to solidify some research funding for kidney cancer specifically in Congress. And then that's led to some research, which we'll be talking about in a minute. And ultimately, we're finding a cure for kidney cancer. I'm going to highlight these in colors. As you look at the slide, each one of these arrows should be up in the right-hand corner, and we're hoping that you'll see the connection between these arrow points and what we're doing. So on the patient education front, one of the things that we realized recently in the last year is as an advocacy organization, people were coming with early diagnosis and looking for information, and KidneyCAN didn't have a lot at the time. And so we set out to change that. And what we've done is we've created a patient resource center. What was highlighted just previously by Sarah was, a lot of resources out there. And we realized that we didn't want to recreate the wheel. We didn't want to go out and do stuff that was already been created that's really well done and valid and up to date. And so we've created our patient resource center into 3 or 4 big buckets. One of the big buckets is around early diagnosis and what happens. The second big bucket is around building a care team, which we've talked about here a little bit, and how important that is to have a multidisciplinary team to help you through this process. And then third, we wanted to talk about what happens with treatment and with clinical trials and how valuable clinical trials are in this space. And then finally, we have a bucket, we talk about living well with cancer and all the different things that go along with living with cancer. So when it comes down to diving down a little bit deeper into education, I spent a lot of time up in Boston and in New England. There are town halls, and I suggested to our team that we have a town hall to talk about some of these things. And I got sort of a thumbs down because I wanted it to be about what's going on in Congress, and everybody said that's a horrible idea. But what we ended up realizing is a lot of people around the country have questions. We wanted to have some experts, and so we created a town hall environment where we bring in experts and allow patients to ask questions from around the country. We just had one in January looking back, looking forward. We had Dr. Martin Voss from Memorial Sloan Kettering in New York and Dr. Robert Uzo from Fox Chase in Philadelphia. And they were able to look back into 2021 and see and tell the audience what had been happening in research. And then we also had Dr. Voss look forward and tell us what's coming down the pike. So it's a good opportunity for patients then to ask questions about that. And then we have, a time to share. Second area in this education support is around Facebook Live. We have a wonderful partnership with the National Kidney Foundation, and they have an interest in sharing how kidney disease in some instances can lead to kidney cancer. And so we've created these Facebook Live programs, which are now out on YouTube and on our website and then the National Kidney Foundation on different topics. Again, we bring in patients and caregivers as well as experts. We talk about nutrition and living well and exercise and the different kinds of impacts on mental health and other things. These are just a few of the titles that we've gone over. Also, this is one I want to highlight. KidneyCAN was founded because we were all on Smart Patients. It's an online forum that connects patients and allows for community. If you haven't heard about it, I highly recommend it. It's a closed forum. It's only, you have to be screened to get into the venue, but it allows for you to share and talk to one another in this community on a myriad of topics. And there's sort of a no holds barred attitude there. You can talk about side effect management. You can talk about new treatment ideas. You can talk about, what other people have experienced. So I highly recommend, if you haven't gone to Smart Patients, take advantage of that. So I want to shift gears to sort of tell you how KidneyCAN got started. So when I was living in Washington, D.C. and met the Knapps, we were going up on Capitol Hill. We realized that no one knew about kidney cancer. No one was talking about it. And so we started just raising awareness with a variety of offices. You can see kidney cancer has been historically underfunded. If you look at this graph, you can see breast cancer had in 2018 162 grant applications just through the ACS, but kidney cancer had 13. And, we've seen this historically. And so one of the things that I was doing and others of us on Capitol Hill were saying is, how does this take place? How do we make some of these breakthroughs happen? And I think all of us know that, kidney cancer research takes people, but it also takes a lot more than just people. And it takes people who are, doing mouse models, and they're doing chemical testing of manufacturing processes, and they're doing basic research. It goes across the board of the types of researches that will lead to that next breakthrough. And as you know, the FDA process takes into account all of this in order, to get to a new therapy for all of us. And so I'm going to ask if one of the NCCN folks can take over here. I hope they're able to take over for me and show you a video that we have produced. So one of the things that we were doing is we wanted to raise awareness more. We knew that was going to take patients and advocates coming to Washington, D.C. or visiting through Zoom to talk to their congressional offices.
KidneyCAN's a nonprofit organization with the mission of putting an end to kidney cancer. We want to accelerate a cure, and we do that by focusing on advocacy, research, and patient education. Advocacy Day is our attempt to bring people from across the country, a small grassroots army, if you will, of kidney cancer stakeholders, and we bring them together, we train them, and we talk about the issues, and we all go up to Capitol Hill and meet with our elected representatives.
What we want to do is not only just raise awareness, but raise the funds for research.
It is an opportunity for someone to, at a higher impact, talk with congressmen, senators, and their staff in regards to funding for cancer research, specifically kidney cancer research.
While this year will look different as we connect via Zoom with our elected representatives, the mission remains the same: to engage and educate policymakers on the needs and the urgency around kidney cancer research funding.
I'm really looking forward, once again, hoping to make an impact in research funding for kidney cancer, and this is one way that I can contribute.
We have found that these days have been very productive in getting the attention of Congress.
We're advocating for an increased funding at the NIH, the National Institutes of Health, as well as through the KCRP, the Kidney Cancer Research Program.
The advocacy has paid off. We got involved and helped that line item grow, and we hope it continues to grow in terms of the dollars dedicated specifically to kidney cancer research.
No experience necessary. That's our tagline. We give an entire toolkit to the advocates so they're ready to go. And it even has a script if they want to use it. We've put some scientific information in there that's not real in-depth. We give a lot of facts and figures, and we give some do's and don'ts.
These people are wonderful, and they help you through everything. And we need you.
Your voice counts. Your story is important. We hear repeatedly the congressional offices, everybody's touched by cancer in this country. And so you can make a connection, tell your story, tell what's going on, and advocate for our position.
So much more work needs done. Somebody's got to do it. The more voices, the more awareness, the brighter the future.
As an organization, we're pleading with folks out there across the country to come and help us. I'm proud to say that through the excellent efforts of one of our lead advocates, Deb Bayan in Atlanta, we have now for our spring advocacy days that are coming up just in about a week, March 7th and 8th, we have over 180 delegates that have registered across the country. We have 37 states represented. And we have, I think, meetings in person with elected representatives, about 20 different senators and congressional offices, as well as their staff. And so this is a chance, if you haven't, we'd love for you to sign up or consider. We come back in August for what's called district days. And anyway, I'll show a little bit of that. You can find more at KidneyCAN.org if you're interested. These are just a couple of snapshots of different delegates that have come with us to Capitol Hill to make our voice heard. And I think, as was said on the commercial there, we started out in 2016. We had $0 of dedicated funding federal funding for medical research for kidney cancer. And then we were fortunate enough to get a line item inserted by our champion Congresswoman Nita Lowey there, who was in one of those pictures. And we got $10 million in 2017. And I'm just proud to say that with all the efforts of the people around this country, we've grown it up to 20 million, 40 million in 2020, and we're now asking for 50 million and maintaining that. And we were successful in the House this year. The House has passed the $50 million again. We're waiting on the Senate to act. As many of you know, we're in sort of a standby period with a continuing resolution, but we're hopeful that the Senate will pass that and we'll have $50 million appropriated for kidney cancer research this year. But we're trying again to go back, and ask for some more, and we could use your help. So if you're out there listening, consider it. It's easy. It's something we'll train you at, and a lot of folks get concerned about it, but we'll walk you through the whole process. So what's next? And what's next is we realized when those first awards were being given out for kidney cancer research that the researchers weren't really talking to one another. And it wasn't intentional that they weren't talking to one another. It was just that was what researchers do. They go into their laboratories and do science and do work and try to find breakthroughs. And so KidneyCAN got together with a couple of other experts, and we pulled some of the researchers out there and clinicians, and we decided, let's bring these folks together and let them share what they're doing. And so the KCRS, the Kidney Cancer Research Summit, was created. It's been led by Dr. Tony Schwery and Dr. Hans Hammers, two leading clinicians and researchers in kidney cancer. And happy to say that Dr. Manley here has been to our event, and we're hoping to have our fourth one this year. Just quickly, an overview of what we've been doing. We've raised over 135 million through the KCRP program, and it's growing. We've got now an army that's out there of grassroots advocates. We funded some of our own trials work, and we're trying to deploy that capital. And we're getting ready to plan for our fourth Kidney Cancer Research Summit, where these researchers can come together. So we've got work to do. As I think you all know, that we have too many people dying every day. We have work in early detection and biomarkers that is needed yesterday, and so much more. And so with that, look forward to answering any questions, and thank you again for this opportunity to share with you all.
Thank you again to all of our presenters. We received a few questions via email, so I'm going to read those first, and then I will address the ones in the Q&A box. So what are your thoughts on kidney regeneration and the klotho protein for people with kidney cancer and chronic kidney disease?
I can take that one. So, you know, not just kidney cancer, but any cancer that affects any organ in our body, right? And we talk about doing surgery to remove that tumor. It often comes with the price of taking out that organ, or at least dramatically decreasing the function. So regeneration of any organ has always been, I don't want to say the holy grail, but one of the pie in the sky things that we as scientists, not just in kidney cancer, have always done. Unfortunately, it's not as easy as, you know, a salamander regenerating its tail. It's a complex biological process, and there's many factors. I always caution patients a little bit on being wary. If it sounds too good to be true, it may be. And this is probably one of those situations. Believe me, if some company is saying they have some way to do something that nobody else, including all of the very expert groups, researchers, institutions, universities haven't done, and you don't see it, you know, all over the place. Like if we had ability to generate kidneys, not just kidney cancer, right? There's a huge need for people who have kidney failure from benign reasons. That would be those people would be winning the Nobel Prize. I can tell you that. So be cautious, you know, sometimes, especially in the cancer journey, when we start getting no answers or answers we don't like to hear, we can sometimes seek things that, again, sometimes can be too good to be true. And especially if those are coming with ask for financials, right, that aren't covered by your insurance, then I think you really got to try and get some other opinions before you make those kind of choices.
Thank you, Dr. Manley. So our next question is about some family histories of bladder and kidney cancer. My dad had bladder cancer and was caught late and metastasized. I had kidney cancer in both kidneys, 1 lesion on my left and 2 on my right. All 3 were low grade. My oldest sister had 2 low-grade lesions on her right kidney, and my middle sister had a tumor in her bladder, which was also low-grade. Both my middle sister and I had genetic testing, and both came back negative. Is there a test to better figure out where this cancer is coming from in our family?
Unfortunately, no, not right now. Like I mentioned at the beginning, we're still learning about all the complexities that come with possible inheritance and predisposition to cancers. And it's not always just the genetics, right? Sometimes patients' exposure to where they lived, you know, they may have been next to some not so great power plants, or, you know, had some toxin. Again, there's a lot of factors that come into place. You could be genetically susceptible, but a lot of times that's not what fully leads to cancer. You need sort of 2 hits in order to do that. But saying that, even though sometimes, and this sounds like a situation where you have all the clinical red flags, but we can't pin it down to a gene, either because it's not one gene, it may be an interplay of many genes. So, you know, there's not a test. Most of the commercial tests available test for the syndromes that I mentioned in here, but that doesn't include all the ones that we're soon to learn about in the future with more research.
Thank you. And it looks like there's a follow-up question about that this person also had several tiny benign cysts on their kidney. And is there a way to treat that without surgery, or is it better left as is if it is not likely to turn into cancer?
Leave it as is. Benign cysts are called benign cysts for a reason. They're benign. So very rarely, and those are typically in patients with like adult polycystic kidney disease. Those patients have literally hundreds of cysts. But we know about 15% of the US population over age 65 has benign cysts on their kidneys. So that by itself is not a need for treatment, although I see plenty of patients and have that question. But there's some characteristics, again, like I defined in there, that sometimes you can have complex cysts, which again, don't always necessitate treatment, often don't. So certainly for a benign cyst, you should never really be getting treatment except for a few sort of exceptional circumstances.
Okay, thank you. Can you please review the recommended treatment for translocation renal cell cancer, as well as prognosis and follow-up testing and timing for the adult patient?
So those are one of the tumor types that I mentioned that we just don't see a lot of. Most of the work that's been done on those tumors has actually occurred in the pediatric population, because it is one of the more common type, not the most, but one of the more common types we see in that patient population. But anytime you're doing a pediatric cancer to an adult cancer, there's usually some significant clinical and biological differences. So in adult patients, we don't have good treatment algorithms for them. Typically, they follow the model like many cancer patients. If it's small and it appears to be the only place, then we try and cut it out. And a lot of patients do well with that. I've certainly had a fair share of these patients. A lot of times we find out after the fact that they're translocation type. There's not a unique pathway for these patients. Unfortunately, when they progress or metastasize, they don't do very well with our current agents, but it's hard because there's so many new current agents, and there is some trials looking specifically at translocation, but these are large trials that require some cooperative groups, many institutions to get together to just have the bare minimum number of patients to see if the treatment or the trial is working or not. So it's hard to study those kind of tumors, unfortunately.
I see. And then I guess the follow-up would be immunotherapy as it relates to translocation renal cell carcinoma. Are there risk benefits? What do we know about that?
So, like I said, we're trying in the immunotherapy drugs we know work for clear cell kidney cancer, and so it makes good sense for us to try this on the other types of kidney cancer, but don't have time. But there's just a lot of biological difference. They're not all the same. They may come from the same organ, but that's where the comparisons end for some of these tumors. So again, immunotherapy is being evaluated in pretty much every cancer in this day and age, right? And translocation and the other subtypes are there too, but we don't have clear data on them as well as of right now.
Okay, thank you. A question about any new treatments for Birt-Hoag-Dubé syndrome?
No. Birt-Hoag-Dubé is one of those classic syndromes. It tends to be these patients, again, their penetrance of kidney tumors are not as high as some of the other ones we see. They can have other manifestations as well, usually pulmonary cyst that sometimes require treatment. But for these patients, they usually benefit from a biopsy because they're almost as likely to develop a benign tumor of the kidney as they are a malignant one. And sometimes the treatment can be radically different for those, obviously. So, but we don't have any specific treatment for Birt-Hoag-Dubé at this time.
Okay, thank you. This question is stage 4 kidney cancer with slow growing cancer common?
I'm going to let Sarah maybe take one of these because I think she's had probably more than a couple of those patients in her treatment.
Thank you. I wouldn't have a really great specific number type of answer, but it is common. A large number of the patients, at least that we see here at Moffitt, the medical oncologists do see stage 4 and are on systemic therapy for a good number of years. And so maybe if you have better numbers, Dr. Manley, but it is common and you can live with it for a decent amount of time. And our goal, especially in nursing world, is to help you live a good life, a good quality during that time.
Yeah, so we know very well that there is some patients where their biology, their disease course is very slow. Unfortunately, you only find that out a lot of times after the fact. So we don't get to use that in our decision making at initial consultation or even subsequent, right? But you can, and we've had these patients where they just develop disease like one spot every few years or longer, and they just grow stable. We don't know how to select or identify those patients up front, which is the biggest problem. If we did, then those patients a lot of times benefit from, treatment holidays, or can be considered for other things like metastatectomy, where we try and take out the lesions and try and quote unquote reset the clock. Especially if patients are older, stuff like that, you can really do them a lot of good by trying to spare them the need for systemic therapy because of the side effects.
Okay, thank you both. So this question, I had my right kidney removed in 2017, but my RCC already metastasized to both knees and femurs. Both knees were replaced and a partial femur replacement with rods. Let's see. So this person did 2.5 years of cabo, xanatinib, and about 2 years of nivolumab. And then they get a PET scan every 3 months to see if it's spreading. It is in my lungs. Is the PET the best way to find new recurrence?
So that's a good question. Like I mentioned sort of in my talk too, PET scan is not traditionally what we use to follow patients either at diagnosis or surveillance or restaging, which is sort of assessing treatment response. Saying that, it's something that's pretty prevalent, especially outside of academic centers where PET scans are used sort of indiscriminately for better or worse. Some providers may feel strongly that that is what they use to identify tumors and stuff, but a lot of times, PET scans can be misleading, right? A PET scan can't tell you the difference between inflammation and cancer. Both of them take up glucose, both of them do those things. So a lot of times, sometimes the PET scan may show things lighting up, but it may not be cancer. Other times it may be, but a lot of times you can get good sense of disease progression with just a good old-fashioned CT scan. But it's really up to your provider on what their comfort level is.
Okay, thank you. How is a non-healing rectal wound managed after a TKI and Pembro?
Again, I'd have to defer to whoever your treating physician is. We know TKIs, and I think Sarah mentioned them, are not good for wound healing. So probably the biggest thing is coming off the TKI. It's hard for anything to heal adequately while you're on those kind of drugs. So if you've been off those drugs and things haven't healed, then it becomes a little more complex, and you probably need to see a colorectal specialist or somebody such as that, because the healing may not be the only part that's contributing to its either persistence or development.
What are signs to look for an immunotherapy treatment is no longer working and should be changed?
It's a really good question. Unfortunately, we don't have a lot of signs. I mean, sometimes depending on where the disease is, you may have signs like for those who present or develop brain metastasis, they usually have neurological signs. For disease that goes to the bone, a lot of times be associated with pain or even a pathologic fracture. But for many of the sites of disease, which are lymph nodes or even lungs or sometimes livers, that you can't tell, just based on how you feel or even signs and symptoms. You need a CT scan to show that tumors are either getting bigger or spreading to new places. And that's basically how we use to determine changing treatments, which is less than ideal. And certainly, like Brian mentioned, one of the active areas of research is looking for better biomarkers, right? That we can catch these things earlier, change treatments earlier, and hopefully extend survival and benefit. But as it is right now, radiographic imaging, which is CT and MRI, is pretty much the standard and the best way to catch these things when they're progressing early.
So here's a follow-up about immunotherapy. Can one receive immunotherapy indefinitely, or should it be discontinued after a period of time?
It's another good question, and we don't have all that answer. Immunotherapy, even though it's been around relatively long, in our arsenal for cancer treatments, it's not like some of the classic chemos, which we know those only have a short amount of time patients can really tolerate. Some patients who appear to be tolerating immunotherapy, especially if it's by itself, very well. And so one of the other research questions we have now that we're getting patients that are living much longer than they did before is, do they need to continue treatment such as this? Or is there a role for possibly discontinuation or doing more of what we consider an adaptive approach, where we take patients off knowing that we may need to put them back on, but if we can spare them some of the side effects in that meantime and still control their disease at an appropriate time, that may be of benefit. But those are all areas that are really being explored. It ultimately comes down to how well you tolerate the drug and how well it's controlling your disease. And again, those are questions that are very good questions to ask your treating provider.
Tanya, can I just jump in here just to add something broader to this, which is, I think these questions are really insightful, and they're highlighting again how kidney cancer research is playing catch up. We've been underfunded for so long that a lot of these questions aren't answered yet. And if we can continue to advocate for additional funding for research, we can start answering some of these questions, and we can get the answers that this audience deserves.
Thank you, Brian. Thank you. Is it possible to receive treatment for RCC while in dialysis?
Yes. It depends on the treatment, right? There's a lot of, when you're, and everyone, very few patients come for the first time diagnosed with kidney cancer and have never seen a doctor, right? So a lot of people have medical comorbidities that need to be considered when both choosing their treatment and undergoing that treatment. They may need more frequent monitoring, adjustment in their dosing. And again, the risk of side effects is probably going to be different too. But we do know that many of these drugs, again, because we're dealing with kidney cancer, where a lot of patients don't have the best kidney function, can do okay for patients on dialysis.
Okay, great. Considering the side effects and risk of the immunotherapy may cause, is it possible to only use targeted therapy first, and when it reaches drug resistance, then change to immunotherapy? Will it lower the efficacy of immunotherapy?
That's a really good question, and we don't know. We do know that before immunotherapy was employed in the standard of care, targeted therapy was it. And so all patients were getting first-line targeted therapy. But we didn't see the responses that we now see with the combination therapy. So, the question is sequencing these drugs better off than sort of putting them all together and giving them up front, which is currently what we're doing with mostly combination treatments. But for some patients, or maybe a lot of patients, we don't know, a more sort of nuanced approach of one drug at a time may be beneficial in slowing the disease for some patients, but also lessening the toxicity. You add more drugs, you add more toxicity. We don't know, and those are very good questions that we need to try and find answers for.
And this will be our last question. So we've had a couple about the chromophobe RCC and just learning more and the pathology report. Where can someone find more information on chromophobe RCC?
So, the best information is going to be your provider. And if you're not comfortable or you want a second opinion, like Brian and his team have put together an excellent resource for patients that you can find some, what we would consider kidney cancer experts in your community. I think reaching out to them. I don't have time to go into all the nuance of chromophobe, but it is a different disease, and treatment is different, management is different. So I think starting with your provider and then getting a second opinion is never a bad thing. You're not offending any doctor that gets offended by you getting a second opinion maybe isn't the place you want to be. So I certainly encourage, and there's lots of times when I'll tell patients, well, let me reach out to so-and-so because they're doing this kind of research or may have answers that I don't know. Chromophobe, for the most part, tends to have a very good prognosis, especially when it's smaller compared to the other sites. So that's a good thing. Unfortunately, for those few patients that do develop metastatic disease, it's hard to study those patients, although there's been some recent trials showing some new treatments that may be beneficial in that unique subcohort of patients. So it's important to have a provider who's familiar, because that data is coming out all the time, and staying up to beat on those kind of treatment management algorithms for tumors that aren't as common, like chromophobe, is really important for those patients.
Great, thank you. So we are out of time for today. I'd like to thank everyone for attending, and again, thank you again to our presenters. The NCCN Foundation would like to also thank the corporate supporters of this webinar.